So, lab investigations in a patient with infectious mononucleosis. This is also something very important you need to note. What is the most common laboratory finding in a patient with infectious mononucleosis? The answer is lymphocytosis. Remember, we are dealing with approach to abnormalities of white blood cells, and that is what led us here. So what is the most common laboratory finding? I can ask you that question and I'll say aplastic anemia, thrombocytopenia, features of disseminated intravascular coagulation, decreased PTT, APT. I can just put so many things, and the answer will be elevated white cell count. Elevated white cell count. Elevated white cell count. So please remember this very well. There can be other things, hemolytic anemia, thrombocytopenia, aplastic, but if there's one thing that I will need to remember, lymphocytosis. Lymphocytosis. Another trick. I have a question. I want to take you back. I said if you have a patient with decreased hematocrit, sore throat, fever, lymphadenopathy, what's your diagnosis? With abdominal pain, what's your diagnosis?
Infectious mononucleosis, ruptured one.
Splenic rupture. Okay, good.
Splenic rupture.
Yeah, okay. Okay, what about if you have a patient with sore throat, lymphadenopathy, fever, malaise, but the monospot test is negative? Can you give me 3 diagnoses you are going to think about, please?
Yeah, cytomegalovirus,
HIV,
CMV,
and
toxoplasmosis, acute HIV.
There we go.
Virus.
There we go. Preparing for a board exam. Preparing for a board exam can be that, simple. So if the monospot test is positive, infectious mononucleosis. If monospot test is negative, I'm thinking about HIV, toxo, cytomegalovirus, human herpes virus type 6, human herpes virus type 7. Now, we've also learned sore throat, lymphadenopathy, abdominal pain, decreased hematocrit, splenic rupture. Another one, sore throat plus abnormal liver function tests. That should also cause you to think about infectious mononucleosis. Sore throat, then you look through elevated liver enzymes. Boom, infectious mononucleosis. So it's about pattern recognition, right, doctors? Okay. So I'm going to keep this because we've already talked about it. Group A strep, cytomegalovirus, HIV, toxoplasmosis. I've taken out HHV type 6 and type 7, but they should also feature here. These are the differentials of sore throat with lymphadenopathy, but negative monospot test. Now, how will you be able to tell, assuming I give you a question stem and I don't bring in the issue of the monospot test, but I focus on fatigue and splenomegaly? How can you use fatigue and splenomegaly to differentiate between infectious mononucleosis and strep throat? Now, usually with strep throat, the patient does not have significant fatigue and splenomegaly. In strep throat, the patient usually will not have significant fatigue and splenomegaly. Cytomegalovirus, because they cannot present with sore throat, they cannot present with lymphadenopathy, they cannot present with fatigue. Cytomegalovirus, you realize that the features are very mild, and liver function tests are also elevated. So we learned something here. I'm asking someone to help me. We learned that if you have somebody with sore throat with elevated liver function, what conditions should you think about? What conditions should you think about, please? Can somebody help me? Cytomegalovirus. And what else?
Infectious mononucleosis.
Infectious mononucleosis. Okay. But then if I have elevated liver enzymes, sore throat, and I'm thinking about cytomegalovirus and infectious mononucleosis, how can I go further to differentiate between the two? It is by looking at fatigue.
Fatigue.
Yes. So in infectious mononucleosis, the patient will be very fatigued. In cytomegalovirus, the patient will not be very fatigued, even though the patient will have sore throat and elevated liver enzymes. Are you getting the whole point?
Yeah.
I want to make sure that we are getting it. So, cytomegalovirus and infectious mononucleosis can both present with fatigue, sore throat, elevated liver enzymes. But the features in cytomegalovirus are less. They are not so high. But with infectious mononucleosis, you realize that the patient is really lethargic. Now back, how do I differentiate between like the sore throat of strep throat and the sore throat of infectious mononucleosis? Can somebody help me?
And the strep,
the fatigue is going to be more
the
in
patient,
infectious mononucleosis.
What about splenomegaly?
Cytomegalovirus is going to be less fatigue.
Exactly.
It's more in infectious mononucleosis.
Now, what about if I'm telling you that the patient is pregnant? It is important when you have a pregnant patient who comes into your clinic or who comes into your ER with sore throat, please make sure that you take your time to swab the patient. The reason is because, you know, with all these differentials we're talking about, HIV, cytomegalovirus, and toxoplasmosis, if we don't swab and we miss these diagnoses, it can have a very bad effect on the baby. Now, can somebody tell me what is one complication of cytomegalovirus in a baby? Can somebody tell me? Cytomegalovirus in a baby.
Deafness.
What?
hearing loss,
Deafness, okay. What about eyes?
Retinopathy.
Okay. So assuming somebody comes to you with sore throat, the patient is pregnant, and you don't swab, and the patient has HIV. Can you imagine the damage you've done to the child? Or toxoplasmosis. So I have a question. What's the effect of toxoplasmosis on a baby? What's the effect of toxoplasmosis on a baby? Can you just give me one?
Erythroblastoma
fetalis.
What?
microcephaly, microcephaly,
chorioretinitis.
Retina, yeah, that's one. And then someone was also saying something else.
Erythroblastosis fetalis too.
Sure, erythroblastosis fetalis. Sure. So, please, in any pregnant patient who comes to you, if you have a question stem like that, make sure that you are swabbing the patient. Because we say that not everyone will have infectious mononucleosis, not everyone has strep throat. Cytomegalovirus is a very big one. HIV is a very big one. Toxoplasmosis is a very big one. Doctors, please. So are you seeing the approach? When we're talking about approach, these are the things I want you to be picking up so that you don't, make any mistakes so far as this exam is concerned. Now, which drugs can also give you features of infectious mononucleosis? So we've learned about the differentials. We've learned about how to differentiate those differentials from infectious mononucleosis itself. We've learned how to use fatigue, how to use splenomegaly, how to use extremes of symptoms. Now, what about medications? There are some medications which can also give you this vibe of, sore throat, tiredness, lymphadenopathy, but then monosport test is negative. And one of those classes of medications is anticonvulsants. Example, phenytoin and carbamazepine. And another group of medications is antibiotics. For example, isoniazid and minocycline. So these medications can also lead to features which look like infectious mononucleosis. These antibiotics can also do the same. Please, can I move on, doctors?
yes.
Okay.
Yes.
So, what if you get a patient, you were thinking this patient may have infectious mononucleosis, but you realize that the patient may not have sore throat, but the patient has lymphadenopathy and splenomegaly. If you have a patient with lymphadenopathy and splenomegaly, which can also be features of infectious mononucleosis, but they don't have, the other features like sore throat and the rest, one differential which should come into your mind should be lymphoma. Lymphoma should also come into my mind. All right. So please, I've talked about lymphoma. I've talked about cytomegalovirus. I've talked about toxoplasmosis, CMV, and HIV in a pregnant patient. We've also talked about how to differentiate them. What did we also talk about? We've talked about lymphoma. We've talked about even the splenic rupture itself.
Talk about medications.
Medications, exactly.